It's Dr. Mark A. Bell. This is the fourth module in our series on cancer screening in primary care. And next we're going to talk about how we identify the optimal intervals and duration of screening, and then dig a little bit into overdiagnosis, an important potential harm that's been newly recognized. So stop and think, maybe jot down a few ideas, maybe pause for a second. What are the factors that should influence when we start screening, how often we screen, and when we stop screening? If you're working with others, it might be a good thing to discuss for a few minutes and come up with some ideas that might guide these decisions. So when should we start? Clearly, we should start when disease is common enough to make screening worthwhile, that there should be a net benefit, more benefit than harm. Below are some data from the U.S. SEER Cancer Registry showing the incidence per 100,000 of various cancers in the population. What you see is that, for example, breast cancer is quite rare among women in their late 20s, becomes somewhat more common in the 30s, and really clearly becomes much more common only once women hit their 50s. There's sort of an intermediate range in the 40s. Cervical cancer goes up, less common early, more common in women who are older. Note that cervical cancer is still diagnosed relatively frequently in older women, but those are primarily women who have not been previously screened or regularly screened. Most cancers continue to get more common as men and women get older, but in many cases, with an advanced age, the time left to live is less than the time needed to benefit from cancer screening. So what about stopping on that topic? If the disease is no longer common enough, but as I just noted, many cancers continue to get more common as you get older. If the person has an expected lifespan less than the typical duration from screen detected to clinically detected disease, that might be sensible. So if it takes 10 years on average for a colorectal cancer to go from a polyp or an advanced polyp to invasive cancer, then someone expected to live less than 10 years would be unlikely to benefit. That's often the rule of thumb that's used. The American Cancer Society recommendations often follow that. And then I think we also have to balance the increasing harms or risks of harms in the very elderly. So for example, colonoscopy in an 80-year-old with multiple morbidities is more likely to experience a complication such as a cardiovascular or a perforation related to that procedure. How often we should screen is also interesting. When Pap smears were first done, they were recommended for women on their birthday. Once a year just has become a convenient habit and was often the starting point for recommendations. Increasingly, as we better understand the natural history of cancers, their dividing time, how long it takes them to grow on average, we start thinking more about optimal intervals. Not letting astronomy be the basis for our decision making, but looking at biology instead. It's an example of an efficiency curve diagram. We saw one of those earlier, and this compares strategies that differ by age at first screening. In the bottom left corner, just a review, on the left y-axis are life years, and along the bottom is colposcopies, again a measure of burden, harm, cost. More colposcopies, generally not a good thing. We'd like to minimize colposcopies and maximize life years gained. You want to be as close as possible to that upper left corner. If you look in the bottom left corner, the black dot is no screening. So just doing any screening at all, starting at age 25 every 5 years is the purple dot, gets you a large gain. But then as you make screening more aggressive, so you're starting earlier, you're doing it more often. Instead of Q5 years, you're doing it Q3 or Q2 or Q1. What you see is the curve begins to flatten out. It's that flat of the curve we talked about, where you're adding burden, you're adding cost, you're potentially adding harm, but you're gaining very little in terms of life years. If you look at the corner where the optimal corner in the upper left, the points on the curve closest to that are in the range of age 20 every 3 years, age 24 every 3 years, And that's typical of when most screening programs around the world start, because they want to optimize that balance between benefits and harms. Next, I want to move on and talk a little about overdiagnosis. This is an important, newly recognized cause of harm. The picture there shows Detroit Receiving Hospital, which is a busy urban trauma center. I happened to be there in one of those buildings back in the early 1990s. Some researchers there did a study of trauma victims, people who had died of either a gunshot or motor vehicle accident or some kind of trauma, and they did a autopsy and looked at the prostate, and they found microscopic foci of prostate cancer very, very commonly, to the point where the majority of men over 60, both African American and white, had evidence of prostate cancer. Now, only 3% of men died of prostate cancer, but the majority had evidence of it in their gland. This was kind of revolutionary and made us start looking at cancer differently than we had before. Certainly the old thinking was that cancer had an inexorable path. It would go from no cancer to a precancerous lesion to an asymptomatic cancer detectable by screening to a symptomatic cancer, and if it was untreated, to death. Now we know that there are a number of potential pathways the cancers can progress, or they can progress slowly, or they can progress so slowly that they never cause symptoms, and in some cases they even regress. So this is a slide illustrating this in a little more detail. The first path, number one, cancer progresses very rapidly or may metastasize early. That makes it not very amenable to screening. Those are often interval cancers, fast-growing, hard to detect due to, remember we talked about that in length time bias. Number two, cancers progress somewhat more slowly. Those detected by screening have more favorable outcomes than those detected later, and that's the case of many breast and lung cancers. And number three, cancer progresses more slowly and would be amenable to better outcomes with earlier treatment, but something else causes the patient's death. A good example would be a lung cancer patient has a lung cancer detected by screening, but then dies of a myocardial infarction related to his or her smoking. And number four, the cancer progresses very slowly, is detectable by screening, but would never have caused symptoms. Those prostate cancers I just mentioned are a good example of that, but we also see it with lung and breast cancer. Number five, you have a precancerous lesion, such as with cervical or colorectal cancer, and removal of that lesion actually prevents cancer. Most cancers with breast cancer screening, for example, lung, prostate, we're not preventing cancer. We're detecting it earlier, but we're not preventing it. With cervical and colorectal, we are in many cases hopefully preventing it by removing those precancerous lesions. And then finally, we can also see regression of early stage lesions. This has been demonstrated in cervical cancer, neuroblastoma, and other malignancies. So if we think about it, the only paths where screening is potentially beneficial are number 2 and number 5. In all of the other cases, screening wouldn't provide a benefit and might even provide a net harm. If we look at the incidence and mortality graph here, incidence is in blue, so cancer incidence, mortality is in red. If we start a screening program, as shown here in 1990, we might detect more cancer than before. That's very common with cancer screening programs, is you'll detect more cancer at the beginning of the program, and you gradually that'll increase, eventually it'll flatten out. If early detection prevents late complications, late deaths due to cancer, we should eventually see that cancer-specific mortality go down. Those early cancers that were detected and treated don't go on to become later stage, more deadly potentially cancers, and so mortality declines. That's the curve we would expect to see for an effective screening program. This is what we might see for an ineffective screening program. Cancer incidence rises again, but mortality stays flat, stays unchanged. We're finding more cancer or things that look like cancer, but mortality is unaffected. Here's some real data, actually, from An article, really good article that I highly recommend, The Clash of Science and Intuition by Jennifer Crosswell and Barry Kramer. They both were working at the National Cancer Institute when they wrote this. And they were responsible for the large PLCO trial that we had talked about earlier. If you look at the thyroid cancer and melanoma in particular, you see something that looks very much like that previous slide. Increasing incidence in gold, but very flat mortality, if anything, increasing a bit for melanoma. For prostate cancer, we see a large rise when the PSA test was introduced, where there was a large inventory of pre-existing cancers that were diagnosed, but then that flattened out. For breast cancer, we see gradually rising incidence as mammography was instituted, but then that dropped a little bit toward the end after the publication of the Women's Health Institute study. What you see with prostate cancer also, and to some extent with breast cancer, is declining mortality, although a fair amount of the prostate cancer mortality reduction probably has to do with better treatment and better surveillance rather than cancer screening, although some of it may also be due to cancer screening. Here's more examples of overdiagnosis. This is thyroid cancer. What we see is that in some countries, if you look at the left-hand side of the graph, South Korea in particular, you see the expected incidence of thyroid cancer with the dotted lines, but then the shading shows the observed incidence of thyroid cancer. So what we see is a huge increase in incidence, about a 14-fold increase in Korea, and that was attributable to widespread use of screening ultrasound for thyroid cancer. And remember, no change in mortality as we saw previously, but just a huge increase in incidence. Where they didn't use handheld ultrasound widely or screen widely, in Australia and the Nordic countries, we don't see that difference at all. Finally, here's some data from an article by Dr. Laura Esserman, Overdiagnosis and Overtreatment in Cancer, an Opportunity for Improvement. This is looking at 3 different pathways like we had talked about before. The first is for breast and prostate cancers, where there's a mix of both aggressive cancers that are amenable to treatment and better outcomes if caught earlier, and also indolent cancers. And what we see, if we look at the breast cancer, there's about a 20% increase in incidence, prostate cancer 54% increase, but for both there's also about a 30% decrease in mortality. Again, partly attributable to better treatment, but potentially some of it also due to screening. In the middle example, we see colon and cervical. Remember, that's where we can remove precancerous lesions, so we see a decrease in incidence due to removing the polyps, removing the precancerous cervical lesions, and a decrease in mortality. So this is kind of a win-win for cancer screening. Finally, if we look at thyroid and melanoma, which we discussed earlier, we see huge percentage increases in incidence, 185, 199%, but essentially no change in mortality or even a slight uptick in mortality with melanoma. So the importance of overdiagnosis really depends a great deal on the cancer and its behavior. And so we have breast and prostate where there's a mix, colon and cervical where there's probably not much overdiagnosis and we see a reduction in both incidence and mortality, and thyroid and melanoma where overdiagnosis is a significant problem. So how much is there? There have been a variety of attempts to quantify the rates of overdiagnosis for different programs. Breast cancer, the best estimate are around 20 to 30%, prostate cancer 30 to 50%, lung cancer around 20%, colorectal and cervical, we probably are overdiagnosing precancerous lesions, but it's really not clear whether there's overdiagnosis of invasive cancers. Overdiagnosis tends to be more common in older patients because they have more competing causes of mortality, more other things that might kill them before they benefit from screening, and less time for the cancer to progress and cause harm, particularly in the very elderly. Shorter intervals between tests, starting earlier, stopping later, in a sense, more aggressive screening is also associated with higher risk of overdiagnosis. We'll see that when we talk about breast cancer screening later. So what can we do about this? So strategies to reduce overdiagnosis. First of all, follow guidelines. Don't over-screen. Don't start earlier than recommended or go later than recommended or do it more often than recommended. Rename cancers like carcinoma and neoplasia, or intermediate lesions that have those words in them, rename them. Ductal carcinoma in situ, high-grade prostatic intraepithelial neoplasia, precursor pancreatic lesions. We need to come up with names that aren't quite as scary, frankly, for these lesions, because when someone hears carcinoma, they immediately think terrible prognosis, which may not be the case for many of these lesions. We need better protocols and standards for evaluating incidentally found items. There's the thyroid TIRADS for thyroid lesions. There are other similar protocols for other incidental lesions, and by following those, we can reduce the number of biopsies, just re-imaging people rather than treating them immediately aggressively. An important area of research is going to be to find better biomarkers and prognostic models so we can figure out which patients with lung cancer have an aggressive lung cancer, which breast cancers are more likely to be overdiagnosed and might be better served by a period of surveillance. So for example, in ductal carcinoma in situ, what's the value of surveillance versus active treatment? So there are some trials underway right now. It's currently standard of care, at least in the US and in many other countries, to do active surveillance for many men with prostate cancer. Thyroid cancer, there are currently some trials underway looking at for specific, more indolent thyroid lesions. Can we monitor those rather than treating aggressively with surgery or radiation? And the same thing for ductal carcinoma in situ. These trials are underway. So back in the first slides, we had some quiz questions